section of the video, we're going to discuss synchronized cardioversion. The procedure for this is available in the emergency care algorithms, which are also available in the casualty app, which you can download on your phone and use for a procedure. Now, before I discuss exactly what the procedure is, I just want to highlight the differences between cardioversion and defibrillation. Okay? Now, the first and major difference is in cardioversion, your patient is alive. Okay? They have a pulse, okay, and potentially are talking to you. Okay? In defibrillation, your patient is not alive, they do not have a pulse, and they're in cardiac arrest mode. Okay? So that's the first major difference. Cardioversion, patient is alive. Defibrillation, patient is not alive. Okay? And you are doing CPR. Okay? The second major difference, of course, is if your patient is alive, then we're going to use less amount of energy on your patient, and we'll discuss the different energy levels we'll use, because we don't need that amount, large amount of shock to be delivered to the patient because they're alive. Okay? Now, the purpose of cardioversion is in a situation where your heart is beating too fast. Okay? So too fast, we normally say above 150. In pediatrics, normally say above 180. So this could be whether it's monomorphic ventricular tachycardia or just any rhythm that's beating really fast. And because of the speed at which your heart is beating, it's not allowing enough time for your heart to fill up with blood, and thus your patient will present with features of shock. Okay, so the indications for cardioversion is, the first one is your heart is beating very fast. Okay, so either most above 150 for an adult patient, probably more than 180 for a pediatric patient. That's the first indication. The second indication is your patient has features of shock. Okay, so they could be hypotensive, altered mental state, okay, chest pain, shortness of breath, any of this, and then of course clinical features of shock. Then in that situation, then you need to cardiovert the patient, okay, to return the heart. So cardioversion essentially terminates the abnormal rhythm that's causing your heart to go to very fast, allowing your normal rhythm to kick in place. All right. So potentially what's going to happen is the patient will present to the emergency department and they'll be complaining, oh, a bit dizzy, a bit sweaty, a bit maybe short of breath, and maybe a bit of chest pain. They could have some of chest pain. So again, your patient is talking to you, and the first thing you want to do, of course, is the moment they get in, make sure you connect them on the monitor without any cables running over the chest to just see what the rhythm is. Okay, so in this particular patient, all right, so I can see my patient's heart rate, okay, is going extremely fast, and it's going at 180, all right? Now, this is a situation where potentially you want to get a rhythm strip, okay? So I'm just going to put back my paper, okay? Okay, so this is a situation where you want to get a rhythm strip, because or 12 lead ECG if possible. So rhythm strip is faster to get. I'm going to pause that there. So a rhythm strip is faster to get because you may not have enough time to get a full lead 12 lead ECG. So printing a rhythm strip allows you to see what rhythm is on there, and you're able to analyze the rhythm. So my patient's rhythm is going very fast. They're a bit confused, they're cold and clammy, BP is a bit low, okay, and I feel that they're in shock, okay? Clinically, they're in shock. Now, the next thing I want to do, of course, then is I want to terminate this abnormal rhythm you're seeing on the screen by cardioverting the patient to then allow your normal heart rate to go through. All right. So the first thing I want to do, of course, is my patient has indication. And remember, you also need to consider some of your H's and T's. Things like hyperkalemia could easily cause this, or drug toxicity. So always have this at the back of your mind, is there anything else that could be causing this very fast heart rhythm? And in which case, then you want to correct that before you shock the patient. Things like hyperkalemia, by easily giving them calcium and dextrose insulin would easily revert the rhythm back to a normal sinus rhythm. A normal rhythm without you having shocked the patient. So always have at the back of the mind, is it a purely electrical problem in the heart, or are there any external factors, for example, toxins, high electrolytes, that could be causing this? All right, so my patient has none of that. Quick history, he's a normal healthy person who just presents with this and in this rhythm. Now, cardioversion, as I said, is your patient is alive, so the first thing I want to do is I want to give them some medication to sedate them a bit and give them a bit of pain relief, all right? Because they're already hypotensive, you don't want to load them with large doses of sedatives and large doses of analgesia. So potentially I'll give them maybe 1 to 2 milligrams of midazolam, and then maybe 25 or 50 micrograms of fentanyl, whatever you have available, but do not give too much analgesia that will make the blood pressure drop further. Remember, the main thing is we need to correct this. All right, now it's very easy to cardiovert a patient, okay? All you need to remember is SMSs, okay? Remember when we used to send SMSs on the phone? So the first S is sync, okay? There's a sync button, okay? So you want to press the sync button, okay? And the moment you press the sync button, you will see on your screen, it should say sync, okay? That's the first thing, SMS, sync. The next thing I want to check is, of course, their markers. Now, if you note, okay, I'll just repeat that. So let me just look at the rhythm. So I've switched off the sync button. All right. So see what happens when I press the sync button. Two things will happen. Okay, there's a sync sign here that shows it's syncing, and there are markers. Now these markers are on the R wave, because the main thing is the machine needs to determine where to shock the patient. So unlike ventricular, now this is the other difference between cardioversion and defibrillation. In defibrillation, the machine shocks anywhere. Okay, the moment you discharge the machine, it shocks the patient. In cardioversion, the machine needs to make sure that it shocks the patient, because you don't want to shock on a T wave. So it marks out all the R waves, because you want to shock at that particular point to terminate the abnormal rhythm, allowing your normal rhythm to come back. So the machine will time the shock at a specific point. Normally this is very fast, but the main thing is, while in defibrillation we were shocking the patient and coming out, okay, in cardioversion you will shock and hold a bit to allow the electricity to be discharged. So sync, that's S. M is for markers. I can see my markers, okay? I can see my markers, okay? Then the other part is select, S is select energy joules. So in this particular patient, with this rhythm, which is a ventricular tachycardia, he has a pulse. Compared to the defibrillation, this one has a pulse. I've already given him some analgesia and some sedation. I'm going to start at 100 joules, okay? All right, so sync, markers, select energy. So I've selected energy at 100 joules, okay? Now the next part of it is I'm going to shock the patient on expiration. Why on expiration? I want to reduce the space. I want to reduce the distance between my paddles on the patient's chest, so that I get the heart pretty much as close to the heart as possible. So sync, markers, okay, select energy, okay. Now I'm going to the shock part, so I'm going to ask my assistant to just give me some gel, okay. He's going to give some gel. It's okay. It's a blob and a blob. All right, so Mr. John, I'm going to shock you a bit. Okay, so I'm ready. So I want to make sure, remember, so I'm gonna charge and make sure everyone is clear, and then shock the patient. Normally it's painful. The patient will probably scream and shout at this point, which is perfectly fine. All right, now I notice my rhythm has not changed, so I'm not gonna come out of here. What I'm gonna do is go through the same process again. I see sync, my sync is on. I see my markers are on. The only difference now is I'm going to go to 150 joules, and then again, so I'm gonna sync. So always confirm sync, markers, I've selected energy to 150, all right? And then I'm gonna shock on expiration. Always counter check, otherwise, because you don't want to defibrillate a patient who is alive. So I'm gonna quickly charge, all right? And shock the patient. Okay, and check if, all right, good. So our rhythm has reverted. All right, and we have a cool tracing on that. Okay, so just some key factors that we need to discuss in terms of synchronized cardioversion. All right. So as I mentioned, the first thing you want to do is make sure you press the sync button. So the indications, of course, is a patient with a very fast heart rate, above 150 for adults, above 180 for kids. So very fast heart rate, okay? And then patient has features of shock, and you can't find any reversible cause like hyperkalemia or something, a toxin that may be causing it that you need to correct. So in terms of procedure, okay, again you make sure this is for adults of course, sync, SMS, sync, markers, okay, select energy, okay, and then please, your patient is alive. They have a pulse, they're talking to you. Give them something for pain and a bit of sedation to prevent the patient from getting too agitated from the pain. Because it's quite painful. Imagine getting electricity shocked into your heart when you're alive. So make sure you give some analgesia. In a ventricular fibrillation, cardiac arrest situation, no need for that. But this patient is alive. So sync, markers, select energy, okay, and then shock on expiration. And if it doesn't work the first time, then again, start again from the top. Make sure your sync is on. Make sure you can see the markers. You move up, for adults, you move to 150 joules. Okay, from 100, maybe go to 150. And then shock on expiration. Now, what if it still doesn't work after 2 shocks? Okay, which is normal, sometimes it happens. Now, there are 3 main reasons. Okay, there are a couple of main reasons that may make a cardioversion not work. Okay, the first one, of course, is you're using less energy, so you just need to go up on the energy dosage. So the energy is not optimal to cardiovert the patient. That's number 1. Number 2, your contact on the patient, okay? You're not applying enough pressure on the patient's chest. Your paddles are not having good contact on the patient's chest. So that could be a second reason why it's not working. The third reason that potentially it's not working is there is something underlying. And this is why, as I said, you need to consider things like hyperkalemia, toxins, or anything that is circulating within the patient's bloodstream that is triggering the heart. And that's one of the things that you may need to consider before you give a third shock, okay? So ideally, before you give a third shock, consider, is it my energy dose could be, so I need to go up on the energy. Am I having good technique, okay? Am I making sure I'm applying enough pressure? Am I having good contact with the skin? And the third part of it is, have I considered other causes like hyperkalemia or toxins that the patient could have in the bloodstream that's causing the cardiac arrhythmia? Okay, if it's toxins, then no amount of shock will convert this. You need to consider the antidotes and potentially then use chemical cardioversion, because that's your other option. When everything fails, then you need to switch to what we call chemical cardioversion, okay, where then we will use drugs to slow down the heart rate. All right. So in summary, synchronized cardioversion is for patients who are alive. That's the first part, okay? So the first thing is they're alive compared to defibrillation where they're dead. So in this situation, there's no CPR ongoing. Patient has a very fast heart rate, above 150 in adults, above 180 in pediatrics. Patient has features of shock, okay? So they are hypotensive, altered mental status, short of breath, chest pain, okay? So any of those features, clinical features suggestive of shock, then they are a candidate for cardioversion. You need to provide some analgesia, just initial dosages. You can always top up when they're back to normal heart rates. Some analgesia, some sedation to take the pain off, and of course tell the patient that you're going to do all this. And then the technique part of it is SMS, sync, confirm with their markers are on, okay, and then select energy joules. Normally you start probably at 100, and then and shock on expiration, all right? And if that doesn't work, go up on the energy joules by 50. Again, SMS, sync, markers, select energy, shock on expiration. And if that doesn't work, consider, is it your technique that is off? Are you using less energy that's required, or your patient has an underlying electrolyte or metabolic problem that's causing the tachycardia that needs to be corrected, and then you can maybe try a third time, and if you've corrected all this and still in let's say tachycardia above 150, then you need to consider consulting a cardiologist to see what can be done next in terms of therapy. There is a tachycardia algorithm in the emergency care algorithms, and a cardioversion procedure is also described in the emergency care algorithms that are available in print copy. You can download them from our website, but also in the Casualty app that you can freely download, again, also from the through our website or Play Store, that you'll be able to then see there how to go through cardioversion, and this video will also be available in that platform.